Hello, I'm Nurul PMP CPHIMS and retired certified, and welcome to CPHIMS-CA exam prep domain Canadian Healthcare System Part 2. In Part 2, we are going to learn how is the delivery system organized and how are providers paid, what are the major strategies to ensure quality of care, what is being done to promote delivery system integration and care coordination, and what is the status of electronic health records in Canada. So let's start. How is the delivery system organized and how are providers paid? We'll learn about physician education and workforce, primary care, outpatient specialist care, administrative mechanism for direct patient payments to providers, after house care, hospital, mental health care, long-term care and social supports. So let's start first. Physician education and workforces. Students who obtained a medical degree from one of Canada's 17 public medical schools paid an average annual tuition of Canadian 40,780, which is equivalent to US dollar 11,730 in 2018 to 2019. About 27% of Canada's physicians receive their degree outside Canada. There are no national programs to ensure supply of doctors in rural and remote locations. However, most provinces have rural practice initiative. For example, Alberta's rural remote northern program guarantees physician an income greater than Canadian 50,000, which is equivalent to US 39,382 US dollar. Now let's see primary care. General practitioner GPs act largely as gatekeepers, and many provinces pay lower fees to specialists for non-referred consultations. Most physicians are self-employed in private practices. In several provinces, network of GPs work together and share resources with variation across provinces in the composition of size of teams. In theory, patients have free choice of GP. In practice, however, patient may not be accepted into physician's practice if the physician has a closed list. The requirements for patient registration vary considerably by province and territory, but no jurisdiction has implemented strict rostering. Quebec, through family medicine groups, has used patient enrollment and added human and financial resources to improve access to care. Fee-for-service is the primary form of physician payment, although there has been a movement toward alternative form of payment such as capitation. In most provinces, specialists have the same fee schedule as primary care physicians. Provincial ministers of health negotiate physician fee schedules for primary and specialist care with medical association. In some provinces, such as British Columbia and Ontario, payment incentives have been linked to performance. Now see outpatient specialist care. Specialists are mostly self-employed. There are few formal multi-specialty clinics. The majority of specialist care is provided in hospitals on both an inpatient and outpatient basis. Although there is a trend toward providing less complex services in non-hospital diagnostic or surgical facilities. Specialists are paid mostly on fee-for-service basis, although there is a variation across provinces. Patient can choose to go directly to a specialist, but it is more common for GPs to refer patients to specialty care. Specialists who bill provincial or territorial public insurance plans are not permitted to receive payment from privately insured patient for services that would be covered under public insurance. Now we'll see administrative mechanism for direct patient payments to providers. The majority of physicians and specialists bill provincial and territorial governments directly. Although some are paid a salary by hospital or facility, patients may require to pay out of pocket for services that are not covered by public insurance plans. Now see after hours care. After hours care is often provided in physician lead walk-in clinics and hospital emergency rooms. In most provinces and territories, a free telephone service allows citizens to get health advice from a registered nurse 24 hours a day. Historically, GPs have not been required to provide after-hours care, although newer group practice arrangement stipulate requirements for financial incentives for providing after-hours care to registered patients. Now see hospitals. Hospitals are a mix of public and private, predominantly not-for-profit organizations. They are often managed by delegated health authorities for hospital boards representing the community. In most provinces and territories, many hospitals are publicly owned. Whereas in Ontario, they are predominantly private not-for-profit corporation. Hospitals in Canada generally operate under annual global budgets negotiated with the provincial Ministry of Health or delegated health authority. However, several provinces including Ontario, Alberta and British Columbia have considered introducing activity-based funding for hospitals, paying a fixed amount for some services provided to patients. Hospital-based physicians generally are not hospital employees and are paid fee for service directly by the provincial ministers of health. Now we'll see mental health care. Physician provided mental health care is covered under Canadian Medicare in addition to fragmented system of allied services. Hospital-based mental health care is provided in specialty psychiatrist hospital and in general hospital with mental health beds. The P&T government, P&T stands for provincial and territorial government, all provide a range of community mental health and addiction services including case management, help for families and caregivers, community-based crisis services and supportive housing. Private psychologists are paid out of pocket or through private insurance. Psychologists who work in publicly funded organizations receive a salary. Mental health has not been formally integrated into primary care. However, some organizations and provinces have launched efforts to coordinate or collocate mental health services with primary care. Now we'll see long-term care, social supports. Long-term care and end-of-life care provided in non-hospital facilities and in the community are not considered insured services under the Canadian Health Act. All P&T government fund such services through general taxation, but coverage varies across jurisdiction. All provinces provide some residential care and some combination of case management and nursing care for home care clients, but there is a considerable variation when it comes to other services including medical equipment, supplies and home support. Many jurisdictions require co-payments. Eligibility for home and residential long-term care services is generally determined via need assessment based on health status and functional impairment. Some jurisdictions also include means testing. About half P&T government provides some home care without means testing, but access may depend both on assess priority and on the availability of services within cap budgets. The government funds personal and nursing care is residential long-term facilities. In addition, financial supplemental based on ability to pay can help support room and board cost. Some provinces have established minimum residency periods as an eligibility condition for facility admission. Public funding home care is provided either through P&T government contracts with agencies that deliver services or through payment stipends to patients to purchase their own services. Provinces and territories are responsible for delivery, palliative and end-of-life care in hospitals covered under Canadian Medicare, where the majority of such costs occurs. But many provide some coverage for services outside those settings such as physician and nursing services and drug coverage in hospices, in nursing facilities and at home. In June 2016, federal government introduced legislation that amended the criminal code to allow eligible adults to request medical assistance in dying from a physician or nurse practitioner. Since that time, P&T government and medical association have set up processes and regulatory framework to allow for medical assistance in dying for individual facing terminal or irreversible illness. Now we'll explore what are the major strategies to ensure quality of care. Many provinces have agencies responsible for producing healthcare system reports and monitoring system performance. In addition, the Canadian Institute for Health Information produces regular public reports on health system performance, including indicators of hospital and long-term care facility performance. Most provinces post summary inspection reports online. Home care agencies do not have reporting standards similar to those for residential long-term care. The Canadian Institute for Health Information has the home care reporting system, which contains demographic, clinical, functional, and resource utilization data for clients served by publicly funded programs across Canada. A variety of other quality initiatives are in progress. The federal funded Canadian Patient Safety Institute promotes best practices and develops strategies and standards and tools. Provincial Quality Council facilitates process improvements to produce higher quality health care. The Optimal Use Projects program operated by the Canadian Agency for Drugs and Technologies in Health provides recommendation, though not formal clinical guidelines, to providers and consumers to encourage the appropriate prescribing, purchasing and use of medication. The federally funded Canadian Foundation for Health Improvement works with P&T governments to implement performance improvement initiatives. Accreditation Canada, a non-government organization, provides voluntary accreditation services to about 1,200 healthcare organizations across Canada, including regional health authorities, hospitals, long-term care facilities, and community organizations. Provincial cancer registries feed data to Canadian Cancer Registry, a national administrative survey that tracks cancer incidence. There is no national patient survey, although a standardized acute care hospital inpatient survey developed by Canadian Institute for Health Information has been implemented in several provinces. Each province has its own strategies and program to address chronic disease. The provincial and territorial premier or prime ministers established the Healthcare Innovation Work Group in 2012 to improve quality by, for example, promoting guidelines for treating heart disease and diabetes and reducing cost. Now we are going to explore what is being done to promote delivery system integration and care coordination. Provinces and territories have introduced several initiatives to improve the integration and coordination of care for chronically ill patients with complex needs. These include Division of Family Practice, British Columbia, Family Medicine Group in Quebec, the Regulated Health Profession Network, NOAA, Scotia, and HealthLink, Ontario. In addition, Ontario has long-standing community-based and multidisciplinary primary care models in place, including community health centers and Aboriginal health access centers. Ontario also continues to expand pilot programs that bundle payments across different providers. This alternative payment approach is expected to improve care coordination for patients as they transition from hospital to community. Now we will see what is the status of electronic health record. Uptake of health information technologies have been slowly increasing in recent years. Provinces and territories are responsible for developing their own electronic information system with national funding and support through Canada Health Infoway. However, there is no national strategies for implementing electronic health records and no national patient identifier. According to Canada Health Infoway, provinces have systems for collecting data electronically for the majority of their population. Okay, that brings us to end of this part of presentation. In next part, we are going to explore digital health initiatives, interoperability, standards, innovative technologies, and privacy and security. I hope you would have found this information useful. If you like my videos, please subscribe to my channel. Thanks for watching. Bye bye.